Dr. Stephen Davis, to my immediate left. Dr. Davis is a Theodore E. Woodward Professor and Chairman of the Department of Medicine in the School of Medicine. He's also Director of the Clinical and Translational Science Research Center and Physician-in-Chief at the University of Maryland Medical Center. Dr. Davis is an esteemed endocrinologist. He leads a team of scientists who are performing cutting-edge research on treating adults with diabetes and diabetes complications, as well as other metabolic disorders. In 2012, the U.S. News and World Report ranked diabetes and endocrinology, that program, as the 11th best in the nation. Dr. Davis's laboratory has found areas in the brain that act to blunt the body's ability to protect itself from hypoglycemia. And his laboratory has identified promising new treatments and interventions that counteract these mechanisms, stimulating the body's ability to defend itself against hypoglycemia. Let me start with some questions that I'll pose first to Dr. Davis. Dr. Davis, diabetes has it's almost becoming a runaway train. There are about 379 million people worldwide with diabetes. In the United States alone, there are about 30 million people, about half of whom know they have it and half who don't. Most of them are type 2 diabetes. Now, the question that I'd like to pose to you, Dr. Davis, and that is there any information that you're aware of or research that you have conducted or your colleagues have conducted in which lifestyle changes, when combined with medical intervention, could potentially prevent, halt, or reverse diabetes and its complications?
Thank you, Al, and thank you for the invitation to come down for this weekend and participate in this important meeting. Let me take a step back and let's define diabetes. Is there anyone here that doesn't know someone who has diabetes, either family member, a friend, or even themselves? Hands up if you know someone with diabetes. Yeah.
Do you know?
You do. You do. Right. So just about 100%. So as Dr. Rees has said, there's close to 30 million people who have diabetes, maybe another 80 million on top of that who are on the cusp of having diabetes. So that's a third of the population of the United States who have diabetes or are going to get diabetes. So what is diabetes? Well, it's a very heterogeneous disorder, best described as a relative lack or total lack of this hormone called insulin. We make insulin from our pancreas, and then insulin controls our blood glucose. What insulin does, it unlocks the cell to make energy, allow glucose to go in. And if you have diabetes, you either don't have enough of this insulin, or the cell does not respond to insulin. So there are three common forms of diabetes in the United States. There's the so-called type 1, which typically occurs in children, may or may not be increasing. There's a big squabble going on in the scientific literature to see if that increases. And what happens there is that the body mounts an attack on the cells that make insulin and destroys it over a period of time, over about 6 or 7 years. And type 1 diabetes makes up about 5 to 10% of this epidemic. The most common is type 2. And then there's a third type that Dean Rees is a world's expert, and that's gestational diabetes. And that typically comes on during pregnancy. It's sort of related to type 2 diabetes, and in most cases, all but 5%, goes away when the baby is born. But women who have gestational diabetes are at high risk, depending on race and ethnicity, of getting type 2 diabetes down the road. Caucasian, 20% risk, African American, Hispanic, up to 60%. But the main problem is this so-called type 2 diabetes. And two things are going wrong there. The body does not make enough insulin, and the insulin does not work. So remember, 9 people out of 10 have got this type 2 diabetes, and it is increasing. Type 2 diabetes is basically doubling every 10 years. So every year in America, 15% of the population will be getting diagnosed with diabetes. So what causes this? Well, you're born with the tendency for diabetes, especially type 2 diabetes. If both your parents have type 2 diabetes, you've got a 66% chance of getting it yourself. The juvenile type does not tend to run in families. In fact, if the father has type 1 diabetes, there's a 10-fold greater risk of the child having type 1 diabetes than the mother. So you might say, well, in that case, if we understand that, why can't we pinpoint individuals who are going to get diabetes? We can, but a very small amount. So there's a few very rare cases where there is just one gene that goes wrong and you get diabetes. But for the common form, this type 2 diabetes, it's many, many genes are involved and it's very, very complicated. So we're born with the tendency to have diabetes. We're born with not enough insulin in these individuals. And then there is a tendency for the insulin not to work. And what makes this get worse and worse over time is obesity. Now, type 2 diabetes is not a lifestyle disease. You don't get type 2 diabetes if you eat too much sugar or sweet things or if you're overweight. What happens is that if you become overweight, that also stops insulin from working. And you get the last straw that breaks the camel's back. And it's not all insulin not all obesity that's bad. So women, for example, carry a lot of subcutaneous fat, more than men. That's good. And in fact, that may actually protect against diabetes. What gets you is when you have this central obesity. So for every 5 and 10 pounds that you put on in your abdomen, that increases the risk. Now, to Dean Rees's point, are there any studies to show that you can prevent diabetes from happening? And there is. There is a famous study that was run by the National Institutes of Health. They got a group of people that were at high risk, these pre-diabetics, and they exercised them a lot, 4 times a week, and they lost about 5% of their body weight. And in another group, they gave one of the common anti-diabetes pills, this pill called metformin that you may have heard about. And they found that if you exercise regularly and you lost a bit of weight, 2/3 of those individuals did not go on to get diabetes. In fact, that was even better than the people that took this diabetic medication, where 1/3 of those individuals didn't get diabetes. But the problem is it takes time. This is a multidisciplinary approach. It's a very complicated disease. And the reason why we have not been successful, either in Maryland or across the country, in translating these research procedures is there's not enough time. There's not enough endocrinologists. There's not enough care providers. And so what we're now moving towards is multidisciplinary clinics where there is a necessary expertise to translate knowledge into preventing disease. The other half of Dean Rees's question is, okay, if you get diabetes, can you revert? And again, in a small proportion of individuals, we can do that. About 10%, so 1 out of 10 people with the type 2 diabetes. Type 1 diabetes, you've got to have insulin shots to stay alive. But type 2 diabetes, about 1 in 10, can be managed on a diet, can be managed on exercise. But they've got to keep working at it, because if you don't, if you let that slip, then it comes back.
Thank you very much, Dr. Davis. Let me ask another follow-up question on that. Let me just sort of pretend that this question was planted in my ear by some of the members in the audience. they want to take something home and really make an impact on their colleagues, their friends, their family members. They happen to have, I'll give you an example, a friend who is overweight or obese and has diabetes. And it's just creating a havoc with their lives. There's glucose all over the place. They're maybe even having some consequence of the diabetes. Is there anything that you have learned from your own research or for your own diabetes practice that you could share, that they can have a practical benefit today, tomorrow, from what you will share with them now?
Yes, so again, thank you for that question. When we think about chronic diseases, we think about, first of all, prevention of the disease. So a cure can be something that normalizes a condition. A cure can be something that is totally preventative. So is there a cure, a vaccine to stop diabetes? Not at the moment. But we do have treatments that can normalize blood glucose, which in and of itself is a cure. But then the question is, well, why aren't we successful? And it's because it's such a complicated condition. And in order to keep one's glucose under control, you've got to think about it all the time. You've got to think about, how am I going to make sure that if I eat something, my blood glucose is not going to go too high? So often people have to prick their fingers to get a blood glucose test and find out whether they've eaten too much or too little. One of the projects that we're working on is what's called a continuous glucose monitor, whereby that you can wear a device that can continuously measure your blood glucose, non-invasively, give you recordings every 5 to 10 seconds, and then that will allow you to judge how much or how little you want to eat, how much medicine you need to take, how exercise is working. So that, we feel, is a major breakthrough, and will be there before some other treatments or advances that will come into play that we may talk about later.
So let me just wrap up as we transition. So clearly, from what you're sharing with us, and that is with your program, the Diabetes and Endocrinologist Center at the University of Maryland Medical Center, you have been able to provide nuances or innovations in treatment that can actually improve both the management and the outcome of certain patients who either are at risk for diabetes or maybe themselves have diabetes, in how to either mitigate the consequences or the complications, or to some extent even reverse it. So I think that for the time being, we're going to just pause at this point and hold that comment unless you want to have a last.
Yeah, it's the complications of diabetes that are the real problem. It's $178 billion spent on diabetes in the US each year, of which about $120 million are the complications. Because just having your blood glucose a little bit high really doesn't matter too much. But what happens if it's not controlled, then it's the leading cause of blindness, it's the leading cause of amputations, leading cause of kidney disease and end-stage renal failure. It's leading cause of heart attacks and strokes. And so, although at the moment we haven't got a vaccine or stem cells that can prevent diabetes, what we can do is that if you get diabetes, we can stop you getting complications. That's called secondary prevention. And what's more, if you get complications, we can stop those getting worse, which is called tertiary prevention. But what we need to do, and we have plans to do this, is a multidisciplinary approach where you will have 12 or 13 different doctors and providers working together in a patient-centered, orientated place. We'll bring the docs to the patients so that we can, in fact, do this while we're waiting for the definitive cure for diabetes to occur.
Dr. David, thank you very much for, again, a very comprehensive review of the programs that you have within your center.